All right, everyone, I'll try to make this as quick as possible. I know we're short for time, but thank you so much, Dr. Morris and team, for inviting me here today. I'll do it the way Jonathan did it. Good almost afternoon, everyone, right? Yeah, I'm here as a messenger for the Engagement Corps. Complete transparency, my role in ADNI is to be a jack of all trades. I've been in developing countries such as Ethiopia, Ghana. I've worked with the refugees in Sierra Leone. I've also worked with the African diaspora in the United Kingdom. I had the privilege of working with the Chin Burmese community when they settled after they had the Civil War in Indianapolis. And so currently, my role in ADNI is specifically to bring individuals who are in underrepresented groups into the study. So for the sake of time, I'm just gonna run through the next slide. Let's see here. All right, and then with regards to this slide, everyone here has been exceptional, contributing to the remarkable success of ADNI. Specifically, I have to acknowledge, of course, Dr. Michael Weiner, Dr. Paul Asen, and Dr. Ronald Peterson, who continue to serve as our ADNI leadership, and they've done so extremely well. And because they pay my salary, I have to mention, I kid. Dr. Oziomo Okonkwo and Dr. Rivera Mint are the co-leaders of the Engagement Corps where I work. I'm privileged to work with them closely every day as they drive the Corps' efforts forward. So jumping into this presentation really quick, we realize, as everyone has mentioned today, that there is an issue. By not capturing the experiences of these underrepresented populations, we really miss out on crucial insights that could help address Alzheimer's disease disparities more effectively. It hampers our efforts to develop targeted interventions where it's most needed. And lastly, the health disparities burden specific populations more heavily, and that magnifies the urgency to address these challenges quickly. So that handsome man over there is Dr. Weiner. He wants us to call him a visionary, and I will do so. Dr. Weiner founded ADNI in 2004, and since its inception, the initiative has produced publications in the thousands. ADNI is widely recognized for its influence on the field, and the primary objectives are multifaceted, as John mentioned. Firstly, it investigates longitudinal changes in cognition, and it sheds light on the progression of Alzheimer's disease. Secondly, it strives to develop predictive models for cognitive decline, empowering us to identify at-risk individuals more effectively. And then also, ADNI rigorously assesses the accuracy of reliability in biomarkers. These measures continuously help us refine treatment approaches. So this is an amazing move and effectiveness that helps clinical trials for targeting Alzheimer's disease. And the problem, we've just mentioned this today. Take a quick look at this. We realize that Latino, Black, and Asian participants screened and enrolled in ADNI is significantly lower when compared to US Census data, mentioned before. To tackle this issue, our aim in ADNI has always been to determine the ethno-racial and educational breakdown, as well as the differences in screening and enrollment. It's imperative that we implement outreach methods that reach underrepresented communities, and by doing so, as mentioned before, we can mitigate the existing disparities and ensure that ADNI accurately reflects the diverse population affected by this disease. So, as a solution, and I was a part of this, I'm so happy to say, ADNI announced in 2020 the formation of the ADNI Diversity Task Force. This task force had a very crucial mission, and it was to accelerate the mission, or actually the enrollment of underrepresented groups during the final 2 years of ADNI 3 as we moved into the ADNI 4 study. Specific tasks were the development of strategies for increasing recruitment, and then also to publish diversity data to enhance transparency and further improve the understanding of health disparities. And then lastly, the task force was actually asked to identify and develop specific aims relevant to health disparities, of course, for this ADNI 4 that was coming on later. So this is our core structure of the Diversity Task Force. First, we selected 15 dedicated members, including a 6-member external advisory board. The board is listed here. I won't go through all the names, but they're amazing individuals. We extend a huge thank you to them for the expertise as they helped shape the initiative of the ADNI Diversity Task Force. We also had 13 diversity recruitment hub sites. These prominent healthcare institutions were committed to promoting diversity within the ADNI project, and the sites are listed in this next slide. Really huge shout out to WashU, which is also there. We're here today. They did an exceptional job. We're very thankful because each of these institutions helped us bring back greater engagement from the underrepresented communities within ADNI. And this is our give slide, which stands for what each task force site was expected to receive during the partnership. We first gave them $150,000 in funding. We were also able to tell each site to attend quarterly meetings where they could share progress and challenges. There was an ad hoc consultation to support what they were offered in case they needed any experts. Furthermore, we had a repository of community engaged resources that were available for sites, and it gave valuable reference for their work. There was a tailored social media campaign, which I'll talk about really quick after this. Each site had a chance to be spotlighted in the ADNI newsletter. I'll pat myself for being able to create that every other quarter. And then periodic webinars were offered to the sites, providing them with updates as we progressed. Lastly, there was the possibility of the renewal in the second year of the collaboration, and that kind of continued the partnership with each site. Protocol changes were also made as an extension of the gives. The first was that we relaxed the LP requirement, so the lumbar puncture requirement was relaxed on a case-by-case. Secondly, sites were given the option to release the amyloid PET results. And then lastly, remote assessments were introduced, enabling the sites to perform assessments remotely when necessary. This next slide is our gets, what we expected from the sites. We wanted them to have at least 5 to 10 Black or Latinx participants to enroll them. Also, we wanted them to participate in the quarterly meetings, as mentioned before. And then lastly, we had them complete a performance metrics in a REDCap survey, and it involved the touches that they had with the liaison the touches at community-based organizations, outreach events, and advertising. That way we could touch every single step from when the participant met with us to the point where they were actually enrolled. So welcome to what we call our secret sauce. I've had food here yesterday. It's not as close, but it's still secret. We had a great opportunity to work with a digital social media campaign marketing firm known as ADNI in San Francisco. And what they did, they took charge of creating a locally tailored Facebook advertising campaign using what we call the Count Me In initiative. This leveraged the power of social media, and it was able to reach a wider audience to gain interest in the ADNI Diversity Task Force. Additionally, they went a step further, and they created local branding landing pages. These pages were specifically designed for each site, and they served as a dedicated space where African American and Latinx potential participants could learn more information and really express their interest. You should have been a part of those conversations. Amazing. So we say a huge thank you to ADNI's marketing because the collaboration really helped us maximize our digital marketing efforts, and they helped us engage face-to-face, sometimes across the internet, with diverse communities. Here are the metrics, which were outstanding. For our first campaign, we garnered an astonishing 2.4 million impressions, and that's the representative of the number of times our campaign was viewed by individuals. Next, we had an impressive total of 25,000 plus ad clicks, and this indicates the amount of times individuals were sufficiently interested in our messaging. We had 2,700 plus web screeners and registrations completed, and for our biggest success, we witnessed 688 individuals enter the website specifically designed for African Americans and 614 for the Latinx community. It demonstrated the effectiveness of our efforts and really helped us engage with the community. So the results, self-explanatory. I'll put them all up here. In a short period, we increased the recruitment of underrepresented populations from 1 to 4. That was an increase of 276%. 3/4 of the new enrollments since February 2021 until the end were from underrepresented populations. And even more striking is the fact that the total URP underrepresented population enrollment increased by a total of 20%. Very astonishing Not to mention, it was during the pandemic. What are critical lessons we've learned? Some of these have been reiterated by the amazing group of people before me. One is the importance of having investigators that are from underrepresented populations and leadership roles. Another is making sure that there's a integration of a community advisory board as well as a scientific advisory board. The local and cultural branded efforts. Very important to work with a marketing firm that not only understands the target audience, but also has a very strong community ownership and experience in marketing for clinical studies. Importance of local site participation cannot be emphasized enough. Our data also suggests that digital marketing is more cost efficient than in-person recruitment. And then lastly, we have also observed that the local involvement remains very critical for long-term retention and sustained engagement. You guys have mentioned that before, our speakers prior. This is a very busy slide. I will jump really quick to the points that I want you guys to see. We have established community partnerships with grassroots efforts as well as local and national organizations. We've created what we call our community research liaisons, and they act as boots on the ground. They assist sites with underrepresented population recruitment. They literally walk them into the sites. We additionally have what we call community research navigators, who are they are a help desk, but pretty much what they do is they are an invaluable resource for potential participants who have questions as they enter our digital cohort. We also have 20 diversity hub sites that we have selected and handpicked because of success and what they offer, but we draw from the lessons that we learned for the diversity task force and apply. Also, we have integrated an ADNI underrepresented group scholars into our training program, and we're just now moving into our second cohort with them. We've also implemented incentives to encourage participation and offer a sampling program where participants can benefit by recommending members from their own network to join. And then lastly, we're engaging in discussions about how, when, and what results specifically from their participation can be disclosed. So these are the specific aims that we came up with, and I'll run through them really quick. We have 2 operational aims. Aim 1 revolves around recruitment and engagement of ethnoculturally diverse cohorts. Aim 2 focuses on workforce training, and that includes site staff and site investigators, also developing a cohort of junior underrepresented populations. And then we have 3 scientific aims. Specifically, what I would like to talk about or just mention are the 3 hypotheses. So 3A suggests that we will observe differences in the rate of Alzheimer's disease biomarker positivity across ethnocentral groups, cultural groups. And then 3B explores the frequency of cognitive impairment, expecting disparities to emerge. And then 3C suggests the presence of effect modifiers, indicating that certain factors may influence the relationship between biomarkers, cognitive profiles, and ethnocultural groups. And then lastly, this slide pretty much explains or just goes over the goals of ADNI 4, which is on its way to getting started. Our first goal, of course, we've accomplished, and that's selecting the people for the engagement core. Next, we aim to reach a digital cohort of 30,000 individuals, and the cohort will be representative with a target of 50 to 60 underrepresented populations. No other way. Within this cohort, our goal is to also identify 6,000 individuals for a plasma AD biomarker study. And then moving on, our enrollment goal includes recruiting 500 new in-clinic participants and 500 rollover participants. Using community-engaged research, I'll end by saying we want to emphasize diversity in our participant population and to ensure that our research reflects a broader population affected by the Alzheimer's disease. So thank you very much. I really appreciate it.